Okay, so that's the anti-malarial agents in a nutshell. Let's move on to the amoebicides. Now, amoebicides are going to be divided into two different groups. Those amoebicides that act systemically in the tissues, and those are for people with systemic infections, and those amoebicides that act exclusively in the bowel wall, and those are people who have more GI-limited disease. Now, you can see that the agents are very similar to the antimalarial agents, chloroquine, metronidazole, tindazole. These are all agents that you've seen before. Luminal amoebicides act on organisms in the bowel wall itself. So these are the agents here that you can see that we use for luminal agents, and we'll go through each of them in detail. Let's start off with the emmentines. So the emmentines are a group of drugs that block ribosomal movement along the messenger RNA. So this is kind of an interesting visual idea. Imagine that messenger RNA is a long railroad track. The ribosome is kind of like a car on a train that just travels along the track. And as it travels along the track, it reads the different code in the messenger RNA and produces a protein. The movement of that ribosome along the railroad track is blocked by this class of drugs, and by that method inhibits protein synthesis, especially for organisms like amoeba. In terms of toxicity, there's quite severe toxicity with these agents, and it's actually extremely common. GI distress is going to be the number one type. You can also sometimes get muscle weakness, and in terms of cardiac muscle, you can get arrhythmia and congestive heart failure. So be very aware of the side effects of these medications. The other agents that we use to kill, to act as amoebicides are metronidazole and tindazole. So we have seen this before in our other lectures on antibacterials. The mechanism of action, we believe, is through bioactivation by anaerobes to form cytotoxic products. Now, there's a nitro group that's reduced by furoxidin that can also be quite toxic too. The drug of choice, this is the drug of choice in severe intestinal wall disease and hepatic abscesses, metronidazole in particular. It works very well in extraintestinal disease as well, so I'm not suggesting that metronidazole can't be used in systemic disease. I'm just suggesting that in terms of luminal disease and hepatic abscesses, it's a very, very good drug. Metronidazole is the drug of choice in trichomoniasis and several other types of amoebic infections or anaerobic infections. Tindazole is effective against metronidazole-resistant organisms, so it is our backup plan when metronidazole doesn't work. Other agents that we use in the treatment for amoebicide activity is diloxanide. Now, it is a luminal amoebicide. It is converted within the gut itself to the freebase form. The freebase form is an amoebicide through an unknown mechanism. It is the drug of choice in asymptomatic amoebiasis, so it's very, very effective. It's used in mild intestinal disease in combination with other drugs. Toxic effects are really related and limited to the bowel, and we're talking about abdominal bloating with a lot of gas production or diarrhea. Iodoquinol is another agent that is considered a luminal amoebicide. It is used in mild to moderate to severe infections, so it's a whole range of infections. Toxic effects, once again, are fairly limited to the bowel, and they tend to be common but not as severe. And people will complain of some mild abdominal bloating, or they'll complain about diarrhea. Overdose symptoms, in overdose, we have to be aware of significant problems, including thyroid enlargement, quite severe skin reactions, and some cases neurotoxicity. And in terms of the neurotoxicity, one of the most feared ones is visual dysfunction, but you can also get a peripheral neuropathy as well. Paramomixin is Paromomycin is also a luminal amoebicide, and it is also an aminoglycoside antibiotic. So we did cover it very briefly in our antibacterial lectures too. It may be superior to other agents in asymptomatic infection, so it may be something that starts to take over, and it may already have done so in your local hospital. It's used in combination with the tetracyclines like doxycycline for mild disease. In terms of toxicity, headaches, dizziness, rashes, and arthralgia are very common with this class of agent and with all aminoglycoside agents. The toxicity risk is going to be proportional to your renal function. So if a person has, stage 3 renal disease, the toxicity risk is actually quite high. So the next drug that I want to mention is nitazoxanide, which is quite a good drug. It has activity against a whole range of protozoan agents. It works quite well against Entamoeba histolytica. It works well against the Helminth class of organisms. It works quite well against Giardia lamblia. And if you recall, that's the one we prosaically call it the Rocky Mountain Runs. That's where you get quite explosive diarrhea from drinking affected river water or lake water. A bit of a note on that. We commonly think of that being something common to the Rocky Mountains because of its name, but in actual fact, it's not just limited to places like Alberta in Canada or Colorado in the United States. It's also present in the Northeast. So it's present in Ontario in Canada. It's present also in places like rural Pennsylvania or New York in the upper northern United States. So don't just think of it as a Western disease. It's also an East Coast disease as well. We also use it against Cryptosporidium. We can also use it in other agents of protozoa too. Now, we also can use this agent in those organisms that are resistant to metronidazole, which is becoming more and more common as time goes on. So I suspect that this drug is going to become more important with time. Now here's the overview of the treatment, and I'll just go over it again. And we also have the final slide as a downloadable image so that you can look at it yourself on your own time. So for asymptomatic intestinal infection, I had mentioned to you before that we like this drug, daloxanide. It's a very, very active agent and it works quite well. In terms of mild to moderate intestinal infections, we move to metronidazole, and we also add in a luminal agent like the one that was listed above. With respect to the severe intestinal infections, we of course are going to use metronidazole. Now, if the agent is resistant to metronidazole, we will substitute tindazole. We will always add a luminal agent with the metronidazole in severe infections. Alternatives can be tetracyclines or one of the emmetines as well, plus a luminal agent. In terms of patients who have hepatic abscesses and other types of extra-intestinal disease, we are going to use metronidazole, or in resistant cases, we'll use tindazole, plus we will add a luminal agent. So you notice that severe intestinal disease and hepatic abscesses are treated essentially the same. So there's the entire graphic. We will have that as a downloadable for you so that you can look at it on your own.